Hello, my name is Portincasa. I'm an internist with special interest in metabolic aspects, and of course, the liver is at the crossroad of such abnormalities. So I would like to share with you my screen and talking about the fatty liver and epidemiology and risk factors. So fatty liver and risk factors, and this is the context. We work at the medical school, Portincasa Hospital in southern Italy, in Bari, beautiful place. When we talk about causes of lipid accumulation, we have to consider excessive accumulation of toxic lipids like triglycerides, free fatty acids, or metabolites like ceramides or cholesterol. Now, if we consider the increased influx of free fatty acids, this might be due to obesity or rapid weight loss or overfeeding or total parenteral nutrition. Also, carbohydrates and proteins transform into triglyceride. They lead to increased fatty acid influx. There might be also a decreased beta oxidation and decreased ATP production by vitamin B5 deficiency or excessive ethanol consumption, or some drugs like valproic acid or chronic aspirin, some decrease of enzymes or accumulation of ceramides. Decreased export of fatty acids as VLDL and serum might be due to a beta lipoproteinemia or protein malnutrition, or defective secretion of postprandial ApoB, or some drugs like amiodarone or tetracycline, or ongoing liver steatosis. And also de novo lipogenesis might be activated with production of triglyceride. If we look at the complex structure of the liver, we should first define steatosis as more than 5% of fat infiltration in hepatocytes, which you see here. And this is the most frequent form is a non-alcoholic fatty liver disease, where is a clinical histopathological entity with histological features resembling alcoholic-induced liver injury, but patients have a little or no history at all of alcohol consumptions. Now, the spectrum of non-alcoholic fatty liver disease ranges from simple steatosis to steatohepatitis, non-alcoholic steatohepatitis with necroinflammation and fibrosis. A group of around 20% might evolve towards cryptogenic cirrhosis, now is an emerging problem, and even a small group towards hepatocellular carcinoma. This is a worrisome trend. And the NAFLD seen worldwide is now the most common liver disorder in Western industrialized countries, and is closely linked to metabolic disorders like central obesity, type 2 diabetes mellitus, dyslipidemia, and metabolic syndrome. But the highways to NAFLD is for sure obesity. This is a terribly worrying trend. Look at what happens in the United States. More than 35% of population are now obese, and this condition will pull other conditions, cardiovascular disease, high blood pressure, type 2 diabetes mellitus, as well as the association will increase over time and age. Also, the prevalence of NAFLD is now estimated to be 20–25%, but there are studies reporting even higher percentages in the United States and the Asia-Pacific regions. The prevalence might go up to 30%. And over the years, from 88 until 2008, this is the increasing trends of NAFLD, which now is 75% of chronic liver disease. However, these estimates might be lower because cohorts with normal transaminasemia were not included. Another worrisome trend is that the metabolic syndrome and even NAFLD is becoming more and more frequent in children who are overweight, who are obese, and who will develop, even before becoming adult, all stigmata of metabolic disorder. And we should stop this worrisome trend. Now, how do we come across NAFLD? Usually, this is kind of ultrasound finding. We will hear more. Hyperechoic liver or heterogeneous parenchyma with already liver cirrhosis, or a mild hypertransaminasemia as a kind of incidentaloma, especially ALT increase in serum. And the age is around 40, 50s, and the gender, well, there are studies showing more common disease in women, some other in men. For example, in the study looking at hepatic triglycerides in thousands of subjects in US, the prevalence was higher in males than females, and was around 45% in Hispanics, 32% in Caucasians, and 25% in Afro-Americans. So there might be differences according to population. But patients with NAFLD and NASH, they have one or more components of the metabolic syndrome. And the criteria listed here increase visceral adipose tissue, which might be different according to ethnic group, increase triglycerides, low HDL, and insulin resistance or diabetes mellitus and hypertension. And of course, fatty liver is here, a fellow traveler of metabolic syndrome, and even other conditions, including cholesterol gallstones, and even other we will see. The ongoing expansion of visceral fat, which you see on the right side of the slide as white tissue, will bring more and more metabolic abnormalities. This is a kind of endocrine tissue, totally different from same weight of striated muscle. This is a very active endocrine tissue. So the increasing trends of metabolic syndrome, now around 45% of people in the world, is another factor which will increase the number of steatosis or steatohepatitis, which are invariably associated with the metabolic syndrome and obesity, as seen in these studies. And also, after correcting for age, sex, and body mass index, the metabolic syndrome is invariably associated with the increased risk of severe fibrosis. This means that all these multiple factors leading to the metabolic syndrome will end up with multiple effects in the cardiovascular field, in diabetes, stroke, and steatohepatitis at most. There's also another dangerous link between liver steatosis and cholecystectomy. When a patient develops symptoms with gallstones, it will be operated. Now there are reports showing that cholecystectomized patients are more likely to develop liver steatosis, something not seen in non-operated patients. Now this is a complex scenario that we contributed to depict, and the bile is stored overnight in gallbladder, flows into the intestine during digestion and a little bit during fasting, as transformed as bile acids in secondary bile acids. They go back to the liver with complex regulatory mechanisms, but also peripherally with metabolic mechanisms. And already in the intestine and the periphery, they act on receptors like GP-bar1 or the nuclear receptors, farnesoid X receptors, all with metabolic effects. Now, in a normal condition, this interaction with the nuclear receptors or GP-bar at different tissues will control lipid homeostasis, glucose homeostasis, and increase energy expenditure at the level of muscle and also brown adipose tissue. However, when the gallbladder, the pump, is missing, this mechanism might be highly dysregulated with impaired lipid homeostasis, impaired glucose homeostasis, and less energy expenditure. What does it mean? Well, Subjects with either cholesterol worsen, with a metabolic syndrome, or even lean with pigment stones, when they become symptomatic, they have to be operated with cholecystectomy. A more rapid enterohepatic circulation will take place without gallbladder, and receptors might be abnormally understimulated. Here is a GP bar, and here is the FXR and the FGF19 as a product, and these abnormalities might lead to excessive deposition of intrahepatic triglyceride, liver steatosis, perpetuating already ongoing metabolic abnormalities with cytotoxicity, and starting a further insulin resistance. Not only, but if patients stay well, because they have no symptoms, they will eat more and more caloric intake, together with this pro-inflammatory status and dysbiosis might further perpetuate this steatogenic damage. NAFLD is also associated with other conditions like polycystic ovary syndrome, hypothyroidism, obstructive sleep apnea, hypopituitarism, and hypogonadism. And so we learned that the metabolic form is the most frequent form. There might be both environmental and genetic contributions. Twin studies show a strong hereditary component, and now genetic variants are emerging, especially the PNPL3 or adiponutrin, which is controlling part of a droplet fats. So the genetic background is now being more and more investigated. If we go back to the influx of fatty acids through diet or from adipose tissue or beta oxidation or export, we should look what happens in a condition of insulin resistance. For example, in a metabolic syndrome, these adipocytes derive products, pro-inflammatory adipocytokines and some hormones will increase this flow of long-chain fatty acids towards the liver. They will be uptaken, insulin resistance will develop, and originally at the first place, triglycerides will be incorporated as a kind of defense mechanism. However, also dietary fats, intestinal microbiota, and sugars might activate other pathways, leading to de novo lipogenesis, further accumulation of triglycerides, ceramides, and cytotoxicity in steatohepatitis. Also working together with decreased export of VLDL, as mentioned before. This lipotoxicity will act not only on the liver, but also on the skeletal muscle, on the pancreas, and on cardiomyocytes, also working together to increase the hepatocellular damage. Less antioxidants, even iron might be important during process of reduction from iron 3+ to iron 2+, and also some hormones, intestinal microbiome, and bile acids. Let's see some of these additional factors. Hormones, for example, increased leptin production from visceral adipose tissue might lead to further steatogenic mechanisms and also might work through a kind of sensitization at the level of the central nervous system with effects on appetite and satiety. Decreased production of adiponectin with decreased levels might increase inflammation and insulin sensitivity and decrease hepatic beta oxidation, another contributing factor. Increased resisting levels will increase glucose intolerance, hyperinsulinemia, and impair suppression of free fatty acids. And also abnormal function of GLP-1, glucagon-like peptide 1, would act on postprandial insulin secretion, glucolipid homeostasis, and hepatic fat content and liver enzyme. And this is a hormone produced by the small intestine. Now, all these factors, together with toxic lipids at the more molecular level, would interact with the receptors and kinases at the level of endoplasmic reticulum, mitochondria, or nucleus, with intracellular signaling pathways and producing more reactive oxygen species, endoplasmic reticulum stress, inflammation, and even cell death. For example, the balance of lipotoxicity might vary between some good lipids, like some types of triglycerides or monounsaturated fatty acids or PUFA, which might store in a more safe way and leading to simple cetosis. But some other lipids like palmitic acids or lysophosphatidyl-choline, ceramides or precholesterol might increase lipotoxicity leading to steatohepatitis. At the level of endoplasmic reticulum also, there might be production of molecules which might result in unfolding protein response, more stress, insulin resistance, cell toxicity. Some other important pathways might also interact with the targets here, the TRAF2, JAN, CHOP, and other pathways, which ultimately would decrease the possibility of beta oxidation of fatty acids in mitochondria, producing also pathways towards caspases 3 and 7, cell death by simultaneously decreasing some defense mechanisms, for example, BCL2 family. At the level of mitochondria, indeed, more free fatty acids would decrease the capacity of production of defense mechanism and antioxidants and beta oxidation. More reactive oxygen species will increase, and also the cycles, TCA cycle, with more glucose production would be active. And to make the short story, this pathway decreasing the capacity of insulin receptor 1 would decrease the propensity of glycogen accumulation in the hepatocytes, and at the same time nuclear mechanism would increase capacity to produce glucose, which will be then released into systemic circulation, increasing insulin resistance, together with damage of the mitochondria that we have seen. Not only, but fatty acids would activate death receptors, apoptosis and necroptosis, and cell death, which together with some protein aggregate would stimulate macrophages, activating inflammasome, and more reactive oxygen species, pro-inflammatory cytokines. And this might explain, through also mechanism of innate immunity, the activation of stellate cells, fibrosis, and further inflammation, typical of steatohepatitis. Recent studies have also attracted the attention towards the role of extracellular vesicles like exosomes and microvesicles, apoptotic bodies coming from intestine, for example, and other signaling proteins acting on hepatocytes, Kupffer cells, endothelial cells, hepatic stellate cells, and inflammatory cells. Very complex mechanism, which should also take into account qualitative, quantitative, or topographic changes of microbiome, like increased bacteroids or increased ruminococcus or decreased Prevotella. Studies are emerging. Dysbiosis in the small or large intestine, increased production of lipopolysaccharides, increased permeability at the level of intestine with production of products and translocation of bacteria or products towards the liver, production of consistent amounts of endogenous alcohol or acetaldehyde at the local level, and further the conjugation of bile acids into secondary toxic bile acids, all factors acting on an already metabolically ill liver. So what can we honestly conclude from this presentation? Well, NAFLD is an emerging problem. Liver steatosis is an emerging problem. The metabolic counterpart of metabolic syndrome is liver steatosis. This is a potentially progressive spectrum of diseases, interesting subgroup of patients. The premium moment is indeed, so far, insulin resistance with increased lipolysis, increased triglyceride synthesis, increased hepatic uptake of free fatty acids, and accumulation of triglycerides. But further mechanisms also include hormones, receptors, membrane glycoproteins, and cytokines. The necroinflammatory process is the more worrisome step and is also due to host factors and partly genetic factors, decreased antioxidant response. Maybe iron is important, and further hepatotoxic byproducts of intestinal bacteria and dysbiosis might be important. And the last step might also involve hepatic fibrogenesis and activation of lobular stellate cells and hepatic progenitor cells. So we can do something at this stage. I have to thank all colleagues, friends who've been helping me in this discussion, including two last researchers from Foie Gras project ongoing Bari. And I should invite you at the next annual meeting of the European Society of Clinical Investigation, taking place next May 2020 in Bari. Thank you very much for your attention.
Thank you. Piero, thank you very much for a nice presentation and difficult from a physiopathological point of view.